local guests and members as well from Sutton and Carshalton. Before I introduce and bring in our speaker for tonight, as always, would like to introduce also our committee with Helen and Lauren. Do you want to give us a wave? Hello. Hi. I'm not sure if we have Nyla, our secretary. Possibly not yet, but that's okay. I'm sure she'll join us later. So look, you know, our year so far. So this is our fourth event, which is fantastic. So far, all events on Zoom. And actually, if we sort of look back at the year, we seem to have covered a number of organs in the context of diabetes. We had a couple of sessions on the heart. We spoke about lungs. We definitely spoke about the eye as well. And talking about the eye, I think today we're taking a slightly different lens. We essentially want to cut this so complex and wide topic of diabetes through the type 1, type 2 lens. And so today's session is focusing on type 1, which is great, to actually give this part of our community actually the right sort of forum as well and engage in conversations. But I'm sure it will be most relevant and also of interest to actually anyone on this call this evening. We have the right person to talk about type 1, namely Professor Parth Narendran, who is from the Institute of Immunology and Immunotherapy at the University of Birmingham, but also in Birmingham, involved and based at the Queen Elizabeth Hospital there. Parth, you qualified from King's College London and then went on to your clinical training across the UK, Manchester, also Bristol, where I believe you sort of started to develop your interest in type 1 when conducting your PhD, but I'm sure you'll give us a way more deeper introduction to yourself and your fascinating career, including actually your stint in Melbourne. So to bring the Southern Hemisphere once again into tonight, clearly you had the exposure there as well. In terms of structure, before I hand over to Parth, we will have sort of two segments really. The one is where, Parth, you will kindly talk to us about one of your research projects that you currently run, the ELSA study, which focuses on type 1 screening. And then I think you'll sort of go slightly broader around the topic of type 1 and sort of talk about trends, sort of latest insights before we open up for a Q&A. And as you know, our members and attendees, the Q&A, there are two ways of getting noticed and involved. You either start shouting, raise your hand on Zoom, or actually if you sort of not feel like shouting tonight, write it into the comment box and we'll pick up your queries, comments, observations as well. I've been speaking now way too much. Parth, I'm handing over to you, and I'm looking forward to the next 40-50 minutes. Thanks so much.
Thank you, Master. Thanks for inviting me. It's really nice. I really enjoy doing these talks. So it's really pleasant to be invited back virtually to South London. So I trained at King's. I guess that would be a hospital that serves some of the people on this call. Is that correct, or is that the wrong part of?
We're probably slightly further out. So ours is Epsom and St. Helier, but you know, King's is never far away.
Yes, brilliant. So I grew up in North London. I started my training in London, and then left and never really came back to London. Oh, and Mahima is from Birmingham as well. So, and I've really enjoyed my time in Birmingham. Actually, been here 16 odd years, having traveled around. So all I do is type 1 diabetes. It's a type 1 diabetes talk. And remember, type 1 diabetes is not but it is a sugar disease. Of course, it's a sugar-related disease, but the background is immunology. It's an immune-mediated disease. It's very different to type 2. The end result is that the sugars are higher, but actually the cause is so different. And we must, in some ways, we need to think about it differently if we're going to optimally manage it. So that's what I'm going to talk on type 1 and meander around a few things. I think the most exciting thing in type 1 diabetes is some of the recent work that's been done in trying to delay type 1 diabetes. So if you look at other autoimmune diseases, multiple sclerosis, rheumatoid arthritis, psoriasis, thyroid disease, they all get immune therapies, and they're all effective in delaying these diseases starting. So why are we not doing that for type 1 diabetes? We've been concentrating on glucose, and of course we should concentrate on glucose. We should use technology and hybrid closed loops and insulin, all of these things. But maybe we can do a little bit better if we think of it as an immune disease. And a lot of the drugs that are used in immune diseases, we could use them in type 1 and see if we can help our patients a bit better. So that's what this is going to be about. So let me just show you some slides if I can. Let's see. I'm not sure what people are seeing. Are people seeing?
We can see the university in the corner.
Great. Are you seeing one slide or lots of slides?
Just one.
Perfect. Perfect. So, and can you see my cursor, Martin? Yeah, perfect. So we're all born with a certain amount of insulin secreting beta cells. Shout at any stage if you need me to stop and explain things. And then, we have these beta cells, and generally, if you look at people who don't develop diabetes, the amount of beta cells gradually increases into our 20s, and then it generally stays there and may gradually decline as we get older. But in people with type 1, and people are born with genetic risk, something happens, and then the immune system, whose job is actually to fight infection, fight cancers, keep us clear of foreign pathogens and illnesses and COVID and all of these things, it's for some reason it thinks the insulin producing beta cells don't belong there, and it starts attacking them. And over a period of many years, you get this gradual loss of these insulin producing beta cells, which go on for many, many years, until it gets to a stage maybe there's 10 or 20% of the beta cells left. And at that stage, they're saying, look, I can't do the job of keeping the sugar under control. So it's only at that stage that the sugar starts to go up. So there's a long prodrome of years. In children, maybe less than that. But if you look at Theresa May, she developed type 1 diabetes in her 40s. This was going on for decades before she got type 1, before her sugar started to go up. So around here, the sugar starts to go up, and then it goes up persistently. And someone says, someone's peeing a lot, drinking a lot, losing weight, they've got type 1 diabetes. And that's when insulin starts. But at the time of diagnosis, people still have some B cell still there. So people have been thinking, hey, here's an immune-mediated disease. Why don't we stop the immune system? We have lots of drugs that stop the immune system. We use it all the time. Not just in these autoimmune diseases that I mentioned, but we give it to people who've had a transplant, where people who've had a heart transplant, lung transplant, kidney transplant, pancreas transplant even, we give them drugs that stop the immune system attacking it and rejecting it. So why don't we use those drugs in these people? And what we've been doing over the last 40 years is giving it to people at the time they're diagnosed, in the hope that you can preserve these remaining beta cells. So why on earth would you want to do that? Because you're not going to stop them taking their insulin. They still need to take their insulin. Well, I think for a number of reasons. One, it tests the system and shows if these drugs are effective and will preserve the remaining beta cells. But also, if you can preserve these remaining beta cells, they help glucose control. Some of you who will have type 1, you'll know that around the time you're diagnosed, you may have had a honeymoon. Your glucose control may have been a little bit easier around the time you're diagnosed. And in people who've had type 1 for decades, as they lose the beta cells, the diabetes control becomes a bit more challenging. So there are some clinical benefits. We know that preserved beta cells at diagnosis reduces glucose variability, reduces hypoglycemia, reduces high glucose levels, has better HbA1c. We know all that. It doesn't stop the insulin, unfortunately. It works alongside the insulin. So there are some clinical benefits. So there's been lots and lots of studies over the last 40 years, 129 studies in people who are newly diagnosed to see if you can preserve the remaining beta cells. Some of these have been vitamins like vitamin D. Some of these have been to see if tight glucose control does it. but most of the studies have been drugs that suppress the immune response, as you may expect for an immune-mediated disease. And then someone finally had the thought of saying, well, let me just summarize very quickly. So they have been effective. They have shown that you can preserve beta cells. But someone finally said, let's take the most promising of these drugs, of these immune drugs, just take one of them and give it to someone before they get type 1 diabetes. So this study came out in 2019, and it's really changed the way we think about delaying and preventing type 1 diabetes. So they gave it to people who are relatives of people who already had type 1, because often relatives are easier to find to see if they're at risk. Most of them were under the age of 18, but a broad age range. And the treatment they gave was an injection of a drug, teplizumab, which is an anti-CD3 drug. So it targets the immune system. It's not a glucose control drug, it's an immune drug. And they gave a daily injection every day for 14 days, and then they sent them home. And then they just followed them up with glucose tests for the next 5 years. There was no other treatment involved, just a daily treatment for 2 weeks. And they showed that you could halve the rates of people progressing to type 1 diabetes. So this really shook our field and has been in lots of press and things, because it gives a precedent for how we may go forward if we want to be serious about delaying type 1. So here's the graph. So here's the proportion who are free of type 1 diabetes. You start with 100, you go down to 0. And here is that months after they were given the treatment, going out to 1 year, 2 years, 3 years, 4 years, 5 years, and you've now got 6 years, actually 6 years of data. The placebo group, the people who didn't get the treatment, gradually dropped off the curve. And by 5 years, about 80% had developed type 1 diabetes. By 2 years, about half of them had developed type 1 diabetes, which is what you'd expect for people at risk. If they'd had that 2-week treatment and then left alone, you halve the rate. So that the risk ratio was 0.4 instead of 1. And instead of 36% being diagnosed every year, there were 15%. So you halve the rates of people getting diabetes. And it was a game changer. Suddenly everyone started thinking, what we need to do is take these drugs we've been playing with and give it to people at risk. Don't give it to them when they're diagnosed, give it to them before they get diagnosed. And it was then you can get some meaningful change. So this got everyone very excited. So NICE, which is an organization you may have heard of in the UK, they look at licensing drugs, and they're the ones who recently said that we can make technology more available for people with type 1 with sensors and pumps and things. They said we need to look at this drug, and they're currently looking at it, and they'll be looking at it in detail and announcing early next year to see if this drug can be given to people at risk of getting type 1 to delay it. And then the FDA, the Food and Drug Administration in the US, the American equivalent of our NICE, they'll be looking at it in November this year. So we're all very excited, because if this is licensed, you're going to have the 100 years from insulin being diagnosed. It's a big year for us. You're going to get the first treatment license for delaying type 1 diabetes. So if that occurs, and even if it doesn't occur, we need to look at other therapies. There's 129 studies I showed you and lots of treatments given to new onset. We need to move those into the prevention arena and see if they can also delay it. We need to combine them with teplizumab. We need to find which patients respond best to some drugs. And we need to think about how we escalate these therapies. So if you think about type 2 diabetes, when I was training at King's, it was only metformin and glycoside. That's all we had. And we had this, we figured out that actually, and we had lifestyle as well. So we'd say, okay, we start with lifestyle. If that doesn't work, you add metformin. If that doesn't work, you don't replace metformin with glycoside, you add it. And then, of course, as you know, there's lots more drugs now for type 2 diabetes. And we're beginning to get an algorithm of which patients do best on which drug and how you'd add them and when you would add them. Right? And for type 2 diabetes, of course, it's HbA1c we use. So we start with lifestyle. If the HbA1c is not getting to target, you add metformin. If that doesn't get to target, then currently the UK and European guidelines says it's open game. You go for whatever you want next. So people are more obese, you might want to go for a GLP-1 analog or a SGLT2. And where cardiovascular or renal protection is important, you might want to go to an SGLT2. So that sort of algorithm you have for type 2. Why can't we do that for type 1 as well and test these other therapies? So that's the way these people are currently thinking. So now into the arena of treating type 1 diabetes as a metabolic disease and delaying the prevention. So the work we're doing in Birmingham, which we hope to extend nationally, is to identify who's at risk. So it's type 1, as you know, is not like type 2. This is not a condition caused, by the same sorts of things. And you can't identify people easily. In type 2, potentially you could do, but in type 1, you can't. And you could say, well, why don't we test just the relatives of people who've already got type 1? And that's good. That's a way of finding them. And of course, you remember that's how that trial was done. That's how they found the people for that teplizumab trial. But the danger is that if you did that, you'd only identify 10 to 15% of the final type 1 population. So most people with type 1 don't have a relative with type 1 diabetes. It comes out of nowhere. And the prevalence of type 1 is about 3 in 1,000 if you don't have a family history. If you do have someone in the family with type 1 diabetes, if it's a first degree relative, so sibling, brother, sister, mom, dad, or child, then your risk goes to 3 in 100. So it's 10 times commoner. If you have a monozygotic twin, if you have an identical twin, then it goes up to about 20, 30%. And if you have a second degree relative, then it's somewhere between that so it's about half of that. So it's about 1.5 to 2%, rather than 3% if it's a first degree relative, if that makes sense. But either way, if you just stick to relatives, you're not going to find your total type 1 population, and you're going to have a lot of people who progress to type 1 who won't benefit from this treatment. So how do we find people with type 1 diabetes? Let's just look at this. So it's an immune disease. So rather than look for glucose is one of the last things to go up as people develop type 1 diabetes. Let's look at markers of immunity, which are antibodies. So type 1 diabetes is because the immune system attacks and damages the insulin-producing beta cells. And as they do that, they generate these antibodies, which we can measure in the blood. Now, the Germans have done some excellent work on this, but also the Finns and the Americans, they looked at how long it takes to develop type 1 diabetes after you've developed these antibodies. So if you do a blood test and find these antibodies in someone and then follow them up, this is the rate of progressing to type 1 diabetes. So here's when the antibodies first appeared, and then 5, 10, 15, 20 years. And here's the proportion who've gone on to get type 1 diabetes. So by 15 years, almost all of them have got type 1 diabetes. So that's the sort of time you need to wait from developing antibodies. The glucose goes up right at the very end. Okay, so if we look at this, what people are saying is that here's type 1 diabetes here. Here's the time before getting type 1 diabetes. And we diagnose diabetes with a fasting glucose over 7, random over 11.1, HbA1c over 48 millimoles per mole. And this is where we've traditionally been saying you've got type 1 diabetes. But what the big organizations are now saying is that actually when antibodies come along, because people are definitely going to get to type 1 diabetes, their sugar will not have gone up, but they're definitely going to get type 1 diabetes. That's when we should be saying they've got type 1 diabetes. So at the time the antibodies appear is when we should call someone as having type 1 diabetes, but call it pre-symptomatic type 1 diabetes because the glucose hasn't gone up. So the American Diabetes Association, which classifies what is type 1, what is type 2, what is MODY, what is gestational diabetes, they're now saying type 1 diabetes appear, you should say someone has type 1 diabetes when their antibodies are present, not when their glucose goes up. So we're also having to think now about how we think about type 1 diabetes. It's not a sugar disease, it's an immune disease. The problem is finding people, because they're going to be fine, but they're going to be walking around. There's going to be no obesity or hypertension or dyslipidemia, some of the things that we associate with pre-type 2 diabetes. We're not going to be able to use those to find people at risk of type 1, and therefore may not benefit from these treatments. So I'm just going to skip that slide. So if we're going to find people at risk of type 1, we need to go out there and measure antibodies. And we can't restrict ourselves to just family members. So how do we define this population? Well, generally, we're thinking we can't find them. We can't use an ethnicity thing. Type 2 diabetes is much commoner in certain ethnicities. We can't use any other criteria. We just have to go and test everyone. So that's what's been happening around the world. The German program, FRIDA, has been going for a number of years now. It's been going out into the general population and can everyone hear me? Yeah. And screening children. The Israeli programs is up and going. JDR Australia started actually this week. The American programs have been going. We've got nothing in the UK for general population screening. I'll just take you through the German program. So this was published a couple of years ago. They went out into the community, and in the German healthcare system, all children go to a community pediatrician every year for an annual checkup, and therefore get a healthcare contact. So they just talk to these community pediatricians and said, when children come, if they're between the age of 2 and 5, please take a blood test and check their antibodies. And remember, we're checking antibodies because it tells you a risk long before the glucose goes up. They screened 100,000 children. They're up to 160,000 now. And 3 in 1,000 had pre-type 1 diabetes, asymptomatic type 1 diabetes. And those people were offered prevention studies. Teplizumab is not currently licensed, so they weren't able to offer that. And the other thing is that, generally around the world, in the Western world, about 1/5 to 1/4 of our children present in diabetic ketoacidosis. It's not that there's no good way to diagnose type 1, but DKA is the worst way to diagnose type 1 diabetes. And whatever we've done, the 4Ts program that the UK have done, there's been a number of programs internationally. We can't seem to get past 1/5 DKA. If you put people into a screening program, you can, though. So for the first time, we were able to reduce DKA at presentation from 20% down to 5%. If there's a slightly better way to be diagnosed with type 1 diabetes, is not in DKA. So there's a number of advantages to this. What about the stress of being told that you're at risk, or your child is at risk of type 1 diabetes, and then just being told you have to wait, you've got to sit and wait for all these years until you get it, and then have these regular tests to make sure the sugar hasn't started to go up. So that was a big concern for them, and it remains a concern for anyone who'd want to do a screening program. Here are the depression scores in the German families and the mums. At the time that they were told that they're 2 antibody positive. So if we go through these are different families. So this is people who, where there's no risk of diabetes, so just control that you can compare with, nice low values. These are families who were diagnosed with type 1 diabetes outside the screening program. These are children presenting in the normal way with a sudden diagnosis of type 1 diabetes coming out of nowhere, much higher risks, anxiety scores and depression scores. In people who We're told they're 2 antibody positive, so these are being told you're at risk. Your child's going to get type 1 diabetes in a number of years, but you know, not just yet. But unfortunately, they are going to get it. You can see that the value is higher than control individuals, but not quite as high as crash landing into type 1 diabetes. And then as the 6 months and 12 months go on, then the depression and anxiety scores come down to that of control. So of course it's anxiety provoking to be told that your child's going to get type 1 diabetes, but it's not as anxiety provoking as being told that you actually have type 1 diabetes, and these do come down. So what are the benefits of screening? Not just relatives, but everyone. You can offer them teplizumab if it's licensed. You can offer them participation in prevention trials to see if you can prevent the type 1 diabetes coming along. And you get improved diabetes control. So not just less DKA, but also the diabetes, the HbA1c appears to be better for a number of years after that because you're diagnosed in a much more controlled fashion. So there's a number of reasons to be doing it. So arguments for screening, potential for intervention, better diabetes control. Against screening is cost, and we're beginning to work out the health economics of all of this, but also harms, the psychological harm of doing this, and how do you plug this into the NHS? So it's going to have to be a large program. How do we establish a national screening program? It's going to be large. You know, you're going to have to screen 1,000 people to find 3. This is quite a bit of work, as opposed to type 2 diabetes, where, you know, in the Birmingham it's about 6%. So it's much commoner. So you might say actually it's more beneficial to screen for type 2 or for other conditions. Is it acceptable? Do people really want to know, or would they just prefer to worry about it when it happens rather than spend a number of years waiting for it to come? And then how does it integrate into the National Health Service? You know, we've got a fantastic system. How do we incorporate a screening program into this? So these are the things we're trying to explore in the British screening program, which we call ELSA. ELSA stands for Early Surveillance for Autoimmune Diabetes. That's our website, elsadiabetes.nhs.uk, and we have started this work now. We'd like to understand 3 things. We've been funded by Diabetes UK as well as JDRF to do this work. Understand the perceptions and acceptabilities of families in the UK. We're very different to Germans, to Americans, to Australians, and you know, we want to find out how the British families feel about being part of a screening program, how they want to be informed about it, how they want to participate in it, and how we can address barriers to recruitment and participation. We want to think about how we recruit into the program. What's the best way to do it? Is it through GP surgeries? Is it online? Is it through schools? What's the best way to recruit? And also think about what doctors, pediatricians, school staff, GPs feel about the whole thing. We're starting this in the West Midlands, and we are starting in the next week or so, and then work on it over summer. Near the end of this year, we hope to go national and do this. We're going to be inviting families who've got children aged 3 to 13 who don't already have type 1 diabetes. So anyone aged 3 to 13 can come in. And we're going to start in the West Midlands, in Birmingham first. We're going to screen 20,000 to start with. We expect about 80 to have 1 antibody, 60.3%, just like the Germans, to 60 to have 2 antibodies, and therefore they will have type 1 diabetes. 6 will actually have symptomatic type 1 diabetes, but not know they've got it. So this is what the Germans found, is a small proportion of those who are 2 antibody positive already had type 1 diabetes and had sugars that were diagnostic of diabetes, but the family hadn't cottoned on yet, or the diagnosis had not been made. And these were the children who were at risk of presenting in DKA. They're just sitting on the edge. And then people who are intermediate, who are double antibody positive, and about to, but on the way to getting it. We're going to try social media. We're going to go into local schools, and not just in Birmingham and West Midlands, but nationally. And we're reaching out to Scotland as well, will be to Wales. We're going to ask GPs to send out invites. We're going to explore whether pharmacies can get involved, TV, radio. we're going to do it largely online because there's such a large number of patients to get out to, online consent, and then test in a lot of different ways. We've got to make it easy for people to do the test. So the idea is that, remember, we're measuring antibodies, not glucose, but we feel that with a drop of blood onto a blotting paper, if the blotting paper is posted to the immunology lab, we can extract the antibody off the blotting paper blood spot, measure the antibodies there, and then that'll tell us the risk. So that's the sort of thing we'll be doing, not just at home. So families may wish to just do it at home on their children, but also at schools or in the communities. So that's the idea. Families will do the blood spot and post it back. It'll be measured. And if it's negative, as most will be, then that's the end of the study. But there will be education offered to families to say, look, the antibody test has come back negative. Thank you for participating in the program. You may not have antibodies now. You may develop it in many years to come. So this doesn't mean you'll never get type 1, but currently now there's very low risk. If it's positive, though, on the antibody, we'd want to test this with a proper arm blood test, a venous blood test. And if that's negative and disproves that original screening test, that's fine. We'll say the same sort of things. If it's positive, then we'll do an oral glucose challenge test, which is a sugar drink test, which will stage what risk they are. But essentially, if they're positive here, then we can say you've got type 1 diabetes, whether it's pre-symptomatic or symptomatic, we don't know, but you're on the pathway to getting type 1 diabetes. Clearly, lots of education will be needed. But at that stage, once we've identified risk, we can then offer them entry into other studies which are currently ongoing in the UK, which are monitoring them to see when they progress to type 1 diabetes, but also importantly, clinical trials, and of course, if appropriate, for treatment with this teplizumab if it's licensed. These are our contacts. These are our website, which currently is just doing some qualitative questionnaire interview research to explore acceptability. And as time goes on, we'll change this. We'll keep the same name on the website, but we'll start offering kits for screening for type 1. Email address, and we have a Twitter handle as well. So general population screening for type 1 diabetes has benefits and is currently happening in a number of countries. We need to find out if and how it works for the UK, and we're due to start later this year. And lots of people involved, not just at the university, the clinical research networks, Cardiff and Warwick universities and Bristol. We've had lots of really fantastic help from our collaborators in the Birmingham Community Healthcare Trust. Remember, these children will not be in hospitals. They will be out in schools. They'll be perfectly, they won't have any healthcare contact. So we need to get out to the communities to do the screening. And we have lots of patients who are part of the study who are very grateful for. So I'll stop there. Don't know if there's any questions.
If you have any questions, now is the time. Unmute yourself. Use the chat window as well.
Hang on. Hi, yeah. Can I ask, initially when you showed how long you did the injection for, it was 2 weeks. Was there a reason you chose that? Had you tried 1 week and 4 weeks?
Yeah, I didn't do the study. This is done in the States. So this is a massive, very expensive study that was done in the States. They could have given it all in one shot, in one infusion, given the total dose. They'd worked out the doses from previous studies, where they'd given it to new onset type 1 diabetes rather than in the prevention area. So they knew what dose they had to give. And then they thought that if they gave it in split doses over 2 weeks, there'll be less side effects. So it's very well tolerated. Some people had a bit of a skin reaction. Of course, the immune cell count went down, as you may expect with that drug anyway. It's an immune drug. But over a month, it came back to normal. And then whenever you give a drug that suppresses the immune system, you're always worried it's going to cause infection because the immune system isn't there to fight infection. There's also a small risk of cancer. But There was none of that in this study. And also this drug has been used in the new onset space over the last 40 years. And they were able to go back to those patients and talk to them. And even over 7 years of follow-up, there was no evidence of a cancer risk or infection risk. So that's why we think it's safe.
Any other questions, observations?
And you talked about once the screening starts in the West Midlands around Birmingham, you anticipated it going national. How quickly is that likely to happen?
So DUK email me every week saying, when are we going to go national? When do we go? And I say, hold on. We're really paranoid about this because we've got to get it right. So this week, we're just going to send out kits just to make sure the postal system works. We need to make sure that the online consenting works and it's secure. We need to make sure that the turnaround of the antibodies is appropriate. We don't want people waiting a month for the antibody results. We'd like to turn it around. We need to make sure that the glucose testing is all set up with the local hospitals, because if they need for the confirmatory venous test and for the glucose drink test, that needs to be done in the hospital. So the pediatric hospitals need to be ready for that. And so we want to take this out really slowly. We want to start with one school. We're going to start with the online first. So that is a long-winded answer to your question. I did tell the UK summer, and then I've revised it to World Diabetes Day, which is 14th of November. It's Banting's birthday, if you know, 14th of November. So what we hope is that sort of over summer we'll be working this up, and then September, October we can start gradually taking this out. And then if we can find pediatric centres in London, which can be ready for people who are screened positive, then we'll go down to London. So World Diabetes Day is when we're expecting the big push. But it depends on everything working. If we compromise this, it creates a bad name. And then when it does work, people just say, I'm not taking part in this because the last time I did it didn't work. So we've got to be really careful everything works. Diabetes centers. So this is a research study. So to ask, to ask a hospital to do it as part of clinical care, it'll be difficult because they're already busy seeing people with established diabetes. This is a research study. It's not part of routine care yet. We hope that this research will help it move into routine care. There's already a number of childhood conditions that we screen for, the newborn phenylketonuria heel prick test that you'll be aware of. So that was done as a small research study that then expanded. So just because type 1 diabetes is a rare condition doesn't mean you shouldn't screen for it. The National Screening Committee have very strict criteria for putting something into screening. You've got to have a treatment for it. We're not there yet. You've got to have a test that's really accurate. We don't want to tell people they don't have type 1 diabetes, but actually the antibody assay wasn't very good. And it's also got to pick up lots of people. And also it mustn't misinform people. So we don't want it being positive when they're actually negative. So all of this really, and then health economics is massive as well. Yeah. So there's a preliminary health economics that's been done in the States. So, one of the things that always reminds me how lucky we are to have the NHS is looking at diabetes care in the States, where even, paying for insulin is very topical, as you know, in the States. Their DKA rates are horrendous. There's some centers with 40, 50, 60% DKA at presentation. When you get up to that level of horrendous presentation, then putting in a screening program makes it financially worthwhile. Thankfully, we're not there. So, because DKA costs a lot to care for financially, then, that high rates of DKA, then it's present. So in order to make it financially viable, we need to not just reduce DKA and the costs associated with hospital admission for DKA, but also reducing insulin treatment, healthcare costs will also make it worthwhile. So if teplizumab is licensed, then we can start bringing that into the health economics. So we're working with health economics experts as well for this. So this is the way we think it'll go. There's a lot of international excitement about this. You know, are we ever going to get to a stage where we do general population screening and roll this drug out? I hope so. It may start that we first start with first degree relatives because they're cheaper and easier to find in a sense. So you have a much smaller population to screen. So we might start with that and then gradually expand to general population.
Is it an expensive drug?
I do. I do. There is a cost. But it's a funny question because they will pitch it. It's owned by Provention Bio, this drug. They will pitch the price, whatever they need to, in order to sell it. So they're waiting for the health economics. So they're also playing a slightly waiting game. So it's a bit like new insulins coming out. You know, the new insulin comes out, they pitch it at a high level, and at what they think they can get for it, and if you know, they need a profit margin because they need the money to go back into researching new insulins. But if they pitch it too high, no one's going to sell it. No one's going to sell it. So they're looking. They've done some preliminary costings to see what they need to pitch it at if you are screening the general population and if you're screening first degree relatives. So they have not fixed it yet. It's not commercially available because it's not licensed. If it is, then I guess they'll do their pitching. Currently, if you want to get your hands on the drug, you've got to approach the company directly. So I have a patient who I tried to get it for. I found out that they thought he was type 2, but actually he was pre-type 1 diabetes because it was just the way he presented. And I tried to get it for him, but he was out of age for it. It wouldn't have been licensed. So you can approach the company directly for it if you want to.
I actually have a question, Parth, if you don't mind. Fascinating when it comes to type 2 is there actually several sort of ways of looking at the correlation between type 2 and, you know, you alluded to race, but obviously there are also socioeconomic factors and so many others. You already said that the racial correlation doesn't exist when it comes to type 1. Is there any correlation to socioeconomic factors at all, or would you say that is also neutralized when it comes to type 1?
Yeah, I think it's pretty neutral. There's not much. There's very little, Marcin. Type 1 diabetes is slightly less common in South Asians, but still, you know, in Birmingham, I have lots of type 1 South Asians. I do think ethnicity plays a role in diabetes. My Afro-Caribbean patients, they often diagnosed type 1, but actually they have a ketosis-prone type 2 diabetes. So they're told they've got, they're presenting DK and told they've got type 1 diabetes, but as time goes on, they find out they can stop their insulin, and they never had type 1. They had a ketosis-prone type 2. So, and then around the world, you get all sorts of different diabetes. It's fascinating. When I worked at King's, I saw a lot of that diabetes. It was called Flatbush diabetes. So traditionally African patients presenting in DK. You say you got type 1 diabetes, start insulin. You see them a few months later, they're on glucoside and metformin. So it's really interesting. But this drug would only work for immune-mediated type 1 diabetes.
Fascinating.
Sun is shining.
Can I just bring in our friends from South Africa? Is there anything that you want to share on specifically on type 1 and the situation of those with type 1 in South Africa? Only if you feel like.
That's a very interesting question. We've been listening with open ears because we have nothing researching pre-type 1s. And it's all very new for us to hear. We have a fair amount of type 1s in South Africa. We in Port Elizabeth have the group called the DSA, which stands for Diabetes South Africa, Young Guns. That is run by 2 adult type 1s, and it is all for type 1s from the age of infants, teenagers, and the young adults. And they get together in informal groups, helping and supporting each other. But we have nothing for the, never heard of before, of the pre-type 1 research. You know, they talk a lot of pre-diabetics for the type 2s, but we've never heard of a type 1s before.
Yeah, I mean, this is new. I mean, we're actually talking to the NHS to say, what are you going to code it as? You know, and every condition is coded. It has a number. And we've got nothing for type 1. So we're actually talking to the NHS code data people to say, what number are you going to give this? And we're going to make sure it's not confused with type 2. That's really important. But I think that what's really a big change has been calling it type 1 diabetes before the glucose goes up. So it's pre-symptomatic type 1 diabetes, because it's like, it's going to happen. You're going to get type 1. We just don't know when. And it's the immune system's on the go. It's going to give you your sugars are going to go up. We just don't know when.
I'm not so sure. Our daughter was diagnosed as type 1 when she was 10. I don't know if I would have liked to have known it from saying that she was on the age of 5. I don't think I would like to have known that it was going to happen. It came as a shock when she was diagnosed.
Yeah.
But
so this is really
better not knowing what's going to happen.
This is really important. This is a Marmite question, you know. We have this thing called Marmite in the UK. I don't know if you have it in South Africa, where, you know, people either like Marmite or they hate it. And this is, I've never, in all the research I've done, I've never come across something that divides people like this. There's some people who say, of course I will have the test. And then the others will say, there's no way I want to know, because I'll just worry for 10 odd years. So this is why when, you know, the first part of our study is really having these interviews with people and saying, do you want to take part? Do you not? What would convince you? And the big thing, generally what we're hearing is that reducing DKA is not enough of a reason for most people to want to know. If there was a treatment, then some of them are saying, yes, I would want to know then. This ability, I mean, we're looking across at some of our colleagues who are doing similar work with rheumatoid arthritis, another immune disease, with a family where, you know, where families, if you have a family member, you're at risk. So there are people saying a lot of people present with rheumatoid arthritis very late when they've damaged quite a lot of their joints. If they'd come earlier, we could have given them these immune drugs like teplizumab, and we could have saved their joints, and they would have much better joints. They'd be much more capable of looking after themselves, opening jars, doing buttons on their dresses and things. So they're saying we should be looking for people earlier. So why don't we screen relatives? And they're doing some of this work. They're a couple of years ahead of us in what they've done. And this critical thing appears to be people's ability to live with risk. You know, there's a risk with everything we do. When you go out the door, you're going to might get run over. You know, how do we live with risk? People who are more able, who are more interested, inquisitive, is one thing. They seem to be the ones who want to go for rheumatoid arthritis screening. Others, you know, this thing about living with uncertainty seems to be another factor, and it's all a very personal thing. Some of us can live with uncertainty, others don't want that, and there's degrees of uncertainty that goes with it. But that's one of the factors that seem to be coming into play here. So it seems to be quite a personal thing. I guess it's a bit. And then the other thing, of course, is also if it's mandatory, you know, the heel prick that's done. We just let it happen because everyone has it. You don't worry about it, and it's just part of routine care. So if that was happening, if there was a strong argument and an effective treatment, and it was just said, everyone, you know, this is what happens. They have everyone gets a screen for type 1, then that may also make it something that's easier to roll out. So this early work is really important. I used to think type 1 diabetes is too rare for the health economics to be worthwhile, but actually, when you look at the heel prick test, which has been going on for decades, as you know, that's a really rare condition, phenylketonuria. But it's a condition that you can diagnose immediately. And if you start treatment, it really changes the life of the child into adulthood. So it's worth screening for that, even though it's an incredibly rare condition. So there's lots of factors that the National Screening Committee takes into account. And screening itself is really interesting because there's now a vogue now with whole genome sequencing. You can take on a sample of blood, you can look at everyone's entire genome. You can actually start looking for conditions which are purely genetic. So type 1 diabetes is a bit of environment, it's a bit of genetics, like type 2. But there are conditions which are purely genetic. And if you pick it up in childhood, you might be able to do something about it from childhood onwards.
Yeah.
So that's the discussion that's currently going through the UK National Screening Committees, what you do with, I mean, I don't know if you know, if you go onto Google straight after this, you through the post in the UK, you can order a bowel cancer screening kit. It's a private company. You just order it. I don't know how much it costs. Arrives in the post. It's you just put some of your poo on it, and it identifies cancer risk. Where does that leave you? I mean, we don't know what the sensitivity and specificity of that are. I think some of us understand sensitivity and specificity a bit more after the COVID, with the COVID tests that were coming through. But that's not licensed by the National Screening Committee or by the National Health Service. But if someone pitches up at the GP and says, I bought this kit privately and it tells me I've got a bowel cancer risk, where does that leave the GP? He will then have to refer the patient through to have their endoscopy done. So there's an interesting interplay in the UK currently between these private kits, screening kits, and the NHS. So the government and the National Screening Committee having to think about all of these things at the moment. So it's a really interesting time for screening. So I've digressed there.
I can see Lauren, you with two hands, your real hand and your virtual hand. I think you wanted to come in.
Yeah, I just had two kind of questions, comments. The first one with, type 1 is rare, but actually, there's been a lot, isn't there, that have said that COVID is likely to cause more type 1 diabetics. So actually, is this going to be kind of more important as time goes on? And whether that theory comes true.
I'm always asked this question. So there's mixed messages. We don't have the answer yet. We will, but we don't yet. There's one thing that is for sure is late presentations of type 1 diabetes in DKA. We've had a lot more DKA presentations because people have found it difficult to get to GPs. So people have been leaving it later and more presenting. So that's definitely happened, not just in the UK, but internationally. The second, are we actually seeing more type 1 diabetes is your question. So I'm not sure about this. And I can see things both ways. One, if you look at the immune thing, if it's going over 15 years, how does COVID last year give you more type 1? It's not going to initiate instruction and just, we don't think. So, we don't think it's going to do that. You'd think that if COVID was precipitating type 1, you'd see it in the literature, in the publication, and in the news. I've not seen much in the news. I've heard lots of people talking about it, but no big national database that said we've got more type 1. So that's the argument against. That said, in Birmingham, we've seen about 3 times as much type 1 diabetes diagnosed this year as before in 2019 and 2018. So, we're not quite sure what's going on. We need some larger database studies to see what's going on. So I haven't answered your question, but it's a good one.
No. And the second part of my question actually was, I know that you were measuring the parental kind of depression or distress with knowing it. Are you measuring from the children's perspective as well?
It's a really good question. We are. Our age is 3 to 13, and the depression and anxiety questionnaires in children are not as developed and validated. We're going to be doing qualitative interviews as well, so we'll pick it up in that. Yeah.
I think there's a couple of questions in the chat if you have time for them as well.
Yeah. Okay, environmental factors. So I think we've discussed COVID. What are the other environmental factors? So probably the biggest influencer, we think, so we know there's an environmental element, because if you take people who've got identical genes, identical twins, if one twin has it, the other one doesn't always get it. In fact, they're more likely not to get it. As I said, it's about 20, 30, 40% concordance if you have amongst one. So there's got to be something else. And the other thing is that type 1 diabetes over the last number of decades has gradually been going up, particularly in the under fives. This is pre-COVID. So you don't get genetic changes that quickly. So there's got to be something in the environment. So we know there's an environmental thing. What is it? Intravirus, a virus that can cause a gut infection is high on the list. And I think there are trials now planned to see if intravirus vaccines can prevent type 1. These are going to be long studies, expensive studies. If you're looking at 10, 15 years of follow-up to see. Rotavirus, I think, is an environmental factor. So some of the rotavirus proteins are similar to proteins in the beta cell. So the immune system, so the thinking is that the immune system, you get a rotavirus diarrhea, the immune system fights it and gets activated towards that protein, and then it seizes it in the pancreatic beta cell and attacks that as well mistakenly. And we also think there's a good argument for rotavirus, because in Australia, when they started a rotavirus immunization program in children, the incidence of type 1 went down. So there's some reasonable evidence there, and we've got rotavirus immunization going on here. So there's a couple of viruses, certainly things like breast milk feeding, cow's milk. There's weak evidence for that. There's been a lot of research on whether breast milk feeding can protect. I'm not sure. There's something about the gut flora. So we've got more bacteria in our gut than we do have cells in our own body. You know, the gut microbiome is incredibly important. And there's some evidence that could be protective. Vitamin D, we still don't have the evidence that vitamin D prevents type 1 diabetes. It works in the mouse models of type 1 diabetes to prevent type 1 diabetes, but we don't see it in humans. There's been lots of prevention studies done with vitamin D that's not come through. So it's a hodgepodge of things that we're still not clear about. Honeymoon, what's the question about honeymoon? Oh, you're on mute, Mahim.
Sorry, hi. Yeah, I was talking about type 1s when they were diagnosed with type 1 diabetes, and they go through a stage of honeymoon period. And like you said, sometimes the doses go down and they think, oh gosh, I don't need insulin, or I don't need insulin at all. I don't have type 1, I've got type 2. But most people afterwards realize when they sort of produce ketones that they're still type 1, but it's just a stage that go through that the pancreas literally shuts off, and it takes probably a couple of years to do that. But in the beginning, when you're diagnosed, you go through a certain stage of honeymoon where you have to sort of, you might think, oh, my sugars are fantastic, I don't have diabetes, I'm not going to take this. But then when your cell doesn't produce anything else, obviously you end up with type 1 diabetes. So that's what I was talking about when you talked about before.
Yeah. So yeah, no, that's a good question. Honeymoon is this, it makes it sound nice, doesn't it? It's also called partial remission. You remember that when people are first diagnosed, they still have some beta cells. And the high glucose that's around when someone's diagnosed often prevents these beta cells working, paradoxically. So they shut down. And then when you give insulin, the beta cells start waking up again. and start chugging away, so you can reduce the insulin dose. Very rarely do we stop it, because it's for exactly that reason. People think they've cured their type 1 and they're presenting DKA later. So we always leave them on a low dose of insulin, and say, look, a time will come when the insulin doses will go up as the rest of your beta cells are destroyed. So we do that. Sometimes we can get away just with a basal insulin. About a lot of people go through honeymoon, more than half of the people go through honeymoon, and they can last for a long time. They can last for years. It's quite a nice period. Most people like it. Some people don't, but most people like it because if you over inject the insulin, if you get your dose right, or dose wrong rather, the beta cells, if you're given too much, the beta cells will shut down. So they're making less to compensate for the fact you've over injected. And if you under inject your dose, they will boost up because they're sensing the glucose all the time. So that acts as a really nice buffer, according to that. And I don't know if we'll have time to get onto exercise, but the reason I got into an exercise because we saw that people who did lots of exercise had much longer honeymoons. And actually, we've done the research to show that if people who exercise have honeymoons that's 5 times longer. And that's because when you exercise, you become much more insulin sensitive. You need less insulin. So there's the remaining beta cells can last for much longer. So that's what I tell all my patients now. If your diagnosis, your exercise is really important. So in people who marathon train, for example, people with type 1, you'll find that their total daily insulin will actually halve over the period of training because they're much more insulin sensitive. It's not just the weight loss and the fact that they're burning off glucose when they're running, but the receptors that take up glucose into muscle and into liver, there's much more of them when we exercise. So you just need a tiny smidgen of insulin and you clear the glucose out of the blood. So it's incredible, isn't it? You can halve your total daily requirements of insulin with exercise. So in the honeymoon period, it's really important to exercise. It's always important to exercise, but it's really beneficial in honeymoon.
Thank you.
Interesting.
Yeah.
I don't know enough about it.
Is that a question, Martin, for all of us? No. So you just said, Parth, do we have time for sort of more slides? I don't know how you structured the sort of next segment, but if there are some sort of news and anything else that you can want to share with us on type 1, that would be now.
Yeah. Do people, are there many type 1s in the audience, can I ask? Yeah. And so when we started this work to see if exercise can preserve beta cells and what's their role in beta cell preservation, we realized that doctors and nurses and dietitians are all rubbish at helping patients to exercise. The advice that's given is very suboptimal. And so I ended up going into supporting and developing with some of my colleagues and friends in other parts of the country. We developed a program to, like Daphne, to support healthcare professionals to support their patients to exercise. That's called EXTOD, EXTOD, exercise for type 1 diabetes. So if you type that into the thing, you'll find that. And it goes through lots of things. So the fact that so the fact that can you see this? Yeah.
Yes. Yeah.
The fact that different exercises do different things. So this idea of if you're going to do some exercise, just have a mini Mars bar is not really going to work, because if you go and lift weights, your sugar's going to go up. And so many doctors didn't even know that. So, if a patient comes to a doctor and says, sorry, I don't know what's happening to my sugars, it's going up when I exercise, and a doctor tells them, don't be silly, that's not going to happen. it's not very helpful for patients, and it puts them off exercise. So generally, if people with type 1 do about 20% less exercise than people without type 1. And it's all these barriers: fear of hypoglycemia, the fact that when you exercise, you become more insulin sensitive, and therefore the next day you need less insulin. That's really tough. If you've got your basals and bolus ratios worked out, and you've got to change it the next day because you've exercised, that's quite a pain, you'd think. So there's lots of barriers to exercise in type 1, and we've got to be supporting people with type 1 to exercise. I always talk about Steve Redgrave, and actually the Commonwealth Games are coming to Birmingham, and every sport, almost every sport in the Olympics and probably in the Olympic Games has someone with type 1 diabetes in it. So it's no barrier to exercise, and we should never let it be a barrier. So, different sports do different things. So aerobic things like cycling, running, long distance swimming, they're going to drop your glucose. Your anaerobic exercise, the weightlifting, is there any question? Wrestling, these bodybuilding, they're going to put your sugar up, and flexibility exercises are not going to do much to your thing. So you've got to think about how you manage these. And then there's lots of other things. So for example, people here with type 1, they might find that if they go for a run in the morning, they're less likely to go hypo than if they do that exact same route and exact same time in the evening. So why is that? You're doing exactly the same thing. Your glucose, starting glucose is the same. It's because when we teach patients about diabetes, we only tell them about one hormone, which is insulin. But actually, there's lots of hormones that control glucose: cortisol, growth hormones, stress hormones, adrenaline, noradrenaline. All of these put our sugar up. And then the glucose value that someone has is a effect of not just the insulin level, but also the other stress hormones. What happens in the morning is that we have higher levels of cortisol. We all wake up with higher levels of cortisol in the morning than in the evening. So many of you will notice that your glucose tends to be higher in the morning than in the evening. And the cortisol makes us more insulin resistant. So you're protected from hypoglycemia if you exercise before breakfast. You do the same run in the evening, you're going to be more insulin sensitive. You're more likely to have a hypo. And of course, you're more likely to be asleep because you've run in the evening. Whereas if you run in the morning, you're more insulin resistant and you're more likely to be awake. Here's the other thing that patients with type 1 have to work on. So in blue is someone, actually here's someone without type 1 diabetes. So in blue is what happens if they don't exercise. Here's breakfast, surge of insulin, lunch, surge of insulin, dinner surge, and there's steps down, and there's Tuesday, there's Wednesday, Thursday, Friday. In someone without type 1, when they exercise, they become more insulin sensitive. The insulin works better. So the pancreas makes less insulin on the exercise day. So when they have their meal, the pancreas makes less insulin, and overnight it's making less insulin. And then over a period of 2 days, the insulin sensitivity goes back to normal. And then by Wednesday, the insulin amount is the same. And then the exercise, so they've had to, and then the next day, if they go for another run, it all changes again. So for someone with type 1, they're going to have to make these basal and bolus changes every day. It's a real pain. No wonder they don't exercise. If you talk to people with type 1 diabetes, they'll say, I'm all right with the exercise period. I'll take more glucose, I'll be fine. It's the next day that's a real pain in the backside. And that's why they don't exercise. It's a 4 hours overnight, the next day, that really messes up things. If you've got to change your basal and bolus ratios. So that's a really big thing. So we say things like this. So on the days after you've exercised, think about reducing your insulin. Reduce your basal. If you're on Levemir, overnight Levemir or Lantus, reduce it by 20% in certain conditions. I won't go into that now. If it's reduce your quick acting by 50% for the next 2 meals, and reduce your correction by 50% for the next 12 hours. So do those 3 things if you're exercising. We call it the 50-50-20 rule. So 50% reduction of normal bolus for the next 2 meals. So if you go out for a game of squash, whether it's an anaerobic or aerobic, you're still going to make yourself insulin sensitive. So you're going to need less bolus insulin for your dinner that follows your squash game in the evening, and you're going to need 50% less also for your breakfast the next day. So try starting with that. You might find you don't need to reduce it for the breakfast the next day. Think about how reducing your correction for the next 12 hours. So if your glucose, you're normally bringing 1 unit to bring you down by 3 millimoles, assume it's going to bring you down by 6. So take half the dose for the next 12 hours. See how that goes. You might find it only applies for 6 hours, but that's our starting advice. And then reduce your lentus or levomir by 20% if you're exercising after 4 in the evening. So your cortisol levels are lower. If you're doing a prolonged period of exercise any time in the day, or if it's a new exercise, we want you to be safe. And there are different rules if you're on pump or MDI. So there's we say there's 3 things you can do to manage glucose during exercise. One is change your insulin, one is change your carbs, and one is exercise itself. So insulin, I won't go into that. I think the most interesting thing you'll find is the exercise. So if you go into the gym and you find that when you're running, your glucose drops, why don't we use this physiology of our other hormones to bring our glucose up? Why do we need to start taking carbs, particularly if we're doing exercise to lose weight? Why don't we just say, let's do anaerobic exercise and bring our glucose levels up? So we teach this to patients and they love it because they're not having to take any carbs. They're not having to change their insulin dose. They're just, as their glucose levels are dropping, change to anaerobic. And similarly, if they're coming off a squash court with very high glucose, if they have the energy, they could walk home or do a prolonged cool down to get the glucose down. We find this really useful in people who are doing running, middle distance running, or middle distance cycling. So they're going for a while and their glucose is dropping. And if they just continued with the exercise, it would drop and drop and drop and drop, and they'd have to take carbs to keep themselves up. But if they put a sprint in, it would take their glucose up, and then they could carry on running and then do a sprint. And so we did this on one of our X-Start courses. We had a guy who said, I've been cycling home from work every day. Interestingly, he didn't describe it in the morning on the way to work, and you can guess why. But on the way home from work, he would say, I'm almost home and my glucose dropping, and I often have to stop and take a drink. And I just said, why don't you try a sprint? You're almost home. You only got a couple of miles to go. Just do a sprint. And the next time we saw him, he said, yeah, it worked beautifully. My kid took my glucose up and it kept it there till I got home. So, all of these little, then we also talk a bit about where that glucose comes from. Where do you think that comes from?
I assume it comes from your liver, doesn't it?
Exactly.
Does your liver do a dump?
Yeah, absolutely right. Perfect. So then, people never think about the liver. You think about diabetes and you think about the pancreas, but the liver is so important. And people with liver disease, outside the context of diabetes, they're all having hypos all the time. It's such an important organ. So when you do your sprint, it pulls glucose out of the liver. So this trick of propping your glucose up with pulling glucose out the liver, it'll work on short distances, but at the end of a marathon, your liver is going to be empty. So it won't work at the end of a marathon. It'll work at the beginning of a marathon. So always have a think about that. So, and we always sort of worry a bit when people go low carb and they want to exercise low carb, because when you're low carb, your liver isn't fully topped up. And if you have a hypo, a glucagon injection is less effective. So, people have a hypo and on low carb diets, you need to stick a needle in them and give them IV glucose if it's a serious hypo. So we always worry a bit about low carb and exercise. So it's fascinating physiology with diabetes and exercise. So that's a little taster. Are the slides available on the x.org site? Yes, they are. Yeah. You need to register. We're thinking of changing that. We've not really developed that as much as we want. We've developed a lot of the healthcare professional bits. The patient one isn't, but all of these slides, you can, once you're registered, you can download them. And we're trying to spin this out into something that we can run like Daphne, because there's such a need for it. That's what people are telling us. There's a big need for this. I don't know if there's any specific questions around exercise that people want to ask.
Can I ask a question, Parth?
Of course, yeah.
Last night we met a lady. She's a type 1, an athlete, but the minute she starts running, her sugar goes up instead of down. Can you explain that first, please?
Of course, it's very easy. It comes back to the fact that insulin isn't the only hormone that manages glucose. There's lots of, so adrenaline will put it up, cortisol, growth hormone, any stress. So we see this a lot in our athletes. They do lots of running. They know exactly how much insulin to take. They know exactly what their glucose is going to be on that day, at that time of that day. And then it comes to race day, if they're in competition, and guess what happens to their glucose? It goes through the roof. And all the rules change, because so everything they've learned and practiced for months all changes on the race day, because they're sitting there, everyone, there's a stress of the competition. There's other people there, you've got to get to the start line on time. So, and that's really challenging. How do you manage that stress? If you give insulin, if you give a little shot of insulin, there's a risk of hypo later. Do you do a short run before you start your marathon? Well, then you're really going to be tired by the time you get to the marathon. So it's thinking about how you manage that. So in people who so people say different things. A lot of them say it starts going up when they start running. Some of them also say it goes up as they're getting to the end of the run. And that's often because the body may be under quite a lot of stress, particularly with long duration type 1 diabetes. And there's also glucagon acting here. So near the end of the run, sometimes people say their glucose starts to go up. So it can be really tricky. But with basic principles like this, we can work it out. And most of us are creatures of habit. So we tend to go for a run on a Sunday. So if you can work out what time most people, most of us start at the same time, finish at the same time, have a set distance. So if you can work out principles for that bit of exercise and optimize it, and people stick with it, then they can have the health benefits and the mental health benefits of exercise. And it's not without too much glucose variability. Hybrid closed loops are really changing things. I don't know how much. Is anyone on a hybrid closed loop here?
There's at least 2 of us.
I don't know. Can we be happy to share what happens when you exercise on?
The loop, because it gets continuous feedback from the sensor measuring your blood sugar, the algorithm predicts whether you're going to go high or low, and it automatically adjusts the basal rate to counteract it. Yeah, exactly. Honestly, it's amazing. It's been life-changing.
Yeah. So in the T-Slim system, it's there's a sport mode. I don't know if you're the Medtronic or T-Slim.
We might be DIY.
So the thing to remember on DIY, so I met a really interesting patient on DIY. He was getting much better control on a DIY system than on a commercial system. He actually took it to the next step. He programmed the GPS. So when he got to his park, he was doing the park run, it would trigger sport mode automatically just on the GPS, which I thought was really clever. The problem is that it takes about about 90 minutes for the basal rate change to actually cause a blood insulin change. So there's a couple of things you need to remember if you're on a hybrid closed loop and exercising. One is you make the change 90 minutes before you start your exercise, if you can. And then because you get so little insulin during the exercise, for the next meal, instead of taking 50% off, take just 25% off the insulin dose. Yeah, if you take 50% off, most people say it's too much. But the great thing most people say about the hybrid closed loop and exercise is that overnight is much safer. You know, the risk, because the hybrid closed loop is for slow changes. Yeah, it's not very good for quick changes. So for overnight, it's a lot better. I think it's the way forward. I hope before I retire, I can put all of my patients onto hybrid closed loop, working as fast as I can to do that.
Here is an ambition. Here is an ambition for your career clearly set out.
Is hybrid closed loop available in South Africa? I'd be interested to know.
Not that we're aware of. So this is all very new to me. And, you know, I think in South Africa, we're kind of restricted in terms of the information that we have, background information, clinical trials when it comes to diabetes. As I mentioned, my son was recently diagnosed with diabetes, and I can honestly tell you it was the most horrific experience for us because as new parents coming to know about this diagnosis, we weren't really explained properly of what this is, what it entails. And, you know, all we were told, it's autoimmune and there's no cure for it. And that's literally the two things that we had to work with. My husband and I had to do a lot of research when it came to this. And we're still trying to come to terms, number one, and trying to understand type 1 as well, because although we have a good endocrinologist, but there's still some things that are still unclear to us, like, for example, how did he get it? And we often told it's genetics, yet there isn't anyone on either end of our families that have type 1. Not that we know of historically as well. So yeah, we're just trying to understand everything. And I think for me, the biggest question is, and I know that there isn't a cure for type 1, but are there any clinical trials being run for a possible cure of type 1 diabetes?
Yeah, for a cure of established type 1 diabetes, or cure before or prevention.
For prevention, is that the only one? Okay.
So prevention is going on. For cure, I guess the treatment is beta cell replacement, isn't it? So you can do, so currently islet cell and pancreas transplantation are for people who are, so the most common thing we're currently doing is, and that's available nationally in the UK, I'm sorry, I don't know what South Africa, most people who get a beta cell replacement get a full pancreas. And usually these are people who are getting a kidney anyway, so they need to take immunosuppression. So they say, let's put a pancreas in at the same time, and that's fantastic. It takes the diabetes away, but they need to take immunosuppression long term. Islet cell transplantation is, it sort of takes the hypoglycemia away. It doesn't actually cure the diabetes, but it's sort of people who've got severe severe hypoglycemia, then we do islet transplantation. That also you need to give immunosuppression for, and you're also limited by donor availability. The thing that we're big excitement is, of course, from Boston about stem cells, and it's moving really quickly. I don't know if we'll get to a stage where if someone's diagnosed, you can top up their beta cells with stem cells. So the idea here is that you take blood off someone, you take some of their stem cells, convert them into beta cells, put them back in, and they don't need immunosuppression because the cells come from that patient, so they're not foreign. So where that is now is, for some reason, the cells still, when they're converted and put back in, they still look slightly foreign, so they still need immunosuppression. So then you're thinking, well, why don't we just give them islets in the first place? But it's moving quickly. So there is growth in that area.
Excellent. I think some positivity, and that's what we want to hear. I mean, I think nobody wants to live with this dreaded disease, but on the other hand, we also know that it's possible to live a good long life with type 1 under the, under good supervision and controlling of it. So thank you so much for that. It's really beneficial. Like I said, based in South Africa, I didn't have much information about this. Doctors were not too clear about everything. So it's always good to get a nice perspective from somebody else outside of the country to see what's actually going on globally as well. So thank you for that. It was really informative.
Thank you very much, Karishma, for sharing your story as well. I'm mindful of time. I think, Parth, you're probably over the time, or have you got the time for one last question? I think there are still some questions in the chat.
Yeah, let me just check what's happening with dinner. 1 second, I'll be back.
Okay, very good idea. Absolutely, getting the priorities right. So look, maybe I'll just mention as Parth is checking sort of dinner with his stakeholders at home. Our next event is on the 1st of October, so after the summer break, and this won't be on Zoom, but for those based closer to home, we're actually meeting for a lunchtime event on, this is a Saturday, the 1st of October, and we will have sort of guests on site, so it's our in-person, face-to-face event for the first event this year. So if you're around, join us. We have interesting speakers, lots of information, and there'll be, if you're a member already, there'll be further communications on it as well. Sorry, Parth, I was just using the break for other information in other news. What's the situation like at home?
Yeah, good. My daughter's cooking, so
lovely.
So hopefully we'll have something edible. I'm sure we will. She's very good.
And I'm sure healthy as well with a dad in that profession.
I don't know about that. Okay.
Martin, were you having a question there? Is that event? Wasn't sure. Is that?
The athlete. I mean, we all know when you run, your sugar goes down, but hers goes up. And that's what Parth answered.
Yeah.
Okay. Wonderful. I see something around the pump. The pump talks to glucose sensor via an app. So you're explaining, Kate, the pump there.
And yeah, somebody asked about how the closed loops worked a bit.
Wonderful. Thanks for sharing. Yeah, get the pump just linked together. And then
exercise and closed loop seems anything that causes a quick change. Let me just see if I can find a slide that might interest you. And anything that changes a quick change in glucose often is difficult for the closed loop to cope with. So so this is this is why you have a hybrid closed loop. So you've got to announce the meal to the closed loop, right? You can't just eat. I don't know how you've set up your system. So an exercise, the other thing. So they're trying to see if they're trying to see if you can build an activity, some sort of activity into the system, which will activity monitor into the system, which can then adjust your pump. But the danger is that it's too slow. So let's just see if I can try to find something. Just trying to find a slide which shows you how long it takes for. So let's just share this. You see that?
Yep.
So this is what people don't realize is when you, with the sensor, when you do a finger prick, you get your glucose straight away, capillary glucose straight away. With the Libra here or with a Dexcom, whatever you're using, you've got a filament and you've got the blood here. So there's a change in glucose here. The glucose molecule has to move through the tissue and get to here. So you're about 20 minutes late. You'll have figured this out, isn't it? There's the sensor about 15, 20 minutes late. Whereas if you prick yourself and actually grab some of this blood with a finger pricker, you get the glucose. And why is that relevant? Because the organ that's most dependent on your blood glucose is your brain. Almost every other tissue can store its own glucose. So it doesn't matter if there's a fluctuation in your blood glucose. Your liver can cope, your kidney can cope, your eyes can cope, but the brain doesn't have a glucose store. So it absolutely needs the right amount of glucose bathing it in the bloodstream. Yeah, so that's why we need to keep our blood glucose stable. So you've got this delay of 15 minutes, which is the first bit of your hybrid closed loop system. And the second bit is when you change your insulin pump, it takes a long time. I was shocked when I first found this out. His percentage change in blood insulin level, sorry, it's small. Percentage change in blood insulin level. And here's time since you make the reduction in your pump. So 2 hours later, you've only got a 10% increase in your insulin. If you take your basal rate up by 25%, 2 hours later, you've only gone up 10%. And this one is even more relevant for exercise. Time since reduction made, 1 hour, 2 hours, 3 hours, and percentage change in blood insulin level. So here in 1 hour, if you do 100% reduction, so you stop your pump and you take it off, an hour later, you've only dropped your blood insulin level by 10%. And if it's 2 hours, you've only dropped it by 30%. So if you start your exercise and you stop your pump, by the time you finish your exercise an hour later, it's not going to have done anything. So that's why the current advice of do a 50% reduction in your basal if you're on a pump, or switch to exercise mode, do that at 90 minutes before, you'll find it's a much more effective thing. But this is quite startling, isn't it? How quickly it changes blood insulin, which is why it's like a cruise liner. It's not a powerboat. It takes a while to change.
Fascinating. Look, I will probably let you go, Parth. I know you have been very generous with your time this evening. It has been very fascinating to listen to you, very informative as well. As I said at the beginning, I think, typically and naturally, given the population breakdown, we sort of focus and cover type 2. So it was really, really important and so good to have you to actually focus on type 1. I would like to say thank you to our friends in South Africa in particular, but also those closer to home. As I said, on the 1st of October, we'll have our face-to-face late summer event here in Carshalton in Southwest London. There will be more communication coming from us. And then just finally from me as well, if you are not yet a member of our local group, but you would like to become a member, get in touch. It is free of charge. As we're still recovering from the pandemic. So a good opportunity to join us and get closer to all the information that is available. A final thank you to you, Parth. Enjoy your dinner.
Thank you.
And we hope to welcome you soon at some stage again.
Thanks for inviting me.